The rage is all about menopause.
If you are born with ovaries, you will enter menopause. If you've ever been surfing, it's kind of like surfing a wave. New joint pain, new hot flashes, new sleep changes, brain fog. These are all generally have some sort of hormonal connection. It goes up, it goes down. Some days it can go up and down in the same day. The menopausal hormone therapy has a bad rap, a scary rap, misinformation.
It really is a movement. You're a doctor, right? Take one. Hi, everyone, and welcome to You're a Doctor, Right? The medical podcast that answers all of your burning medical questions. And I'm excited today to talk to Dr. Kristi DeSapri, who is an expert in the hot topic of menopause. So before we even get started on this topic, I just want to thank you, Kristi, for you. I just saw your recent segment with Dr. Mary Claire, for all the women out there that are really paving to this road. I heard you talk about on this segment that it's really a movement, and it really, really is a movement. I have my friends in their 20s and 30s talking about menopause but previously I feel like we weren't talking about it at all. And if we were talking about it, it was definitely women in menopause or in perimenopause. So I think it's just so incredible what you as experts are doing, just really raising awareness for this incredible topic. So thank you for being here today.
Oh, thank you, Sonya. I'm so excited. Talking about perimenopause and menopause is one of my favorite things to do in and outside of the office. So thank you.
Well, I think it's really, the rage is all about menopause. So we're just honored that you're here. Maybe we can start with you just telling us how you got to the space that you're in. I think about medical school and how we really didn't learn a lot about menopause. So I always find it fascinating to see how you ended up finding this field. Before we get started on our episode today, I want to remind all listeners that the content of this podcast is for informational purposes only and does not constitute formal medical advice. Do not delay in seeking professional medical care because of something that you have heard in this podcast. If you have any questions regarding your own health, please talk personally to a doctor or other healthcare professionals. Relying solely on the information provided in this podcast should be done so at your own risk. Now that we're done with the paperwork, let's get started on this episode today.
Well, I always like to start with some statistics. So you're right. Okay. We learn less. Most residents, even OB-GYN residents, internal medicine residents, get less than an hour of education on menopause during their whole 4-year career. Hopefully that is changing with more advocacy and education, as you mentioned. But I started actually in an OB-GYN thinking I was going to deliver babies and be an obstetrician, and quickly realized I really liked what happened after to women and really talking about the post-reproductive years. So I switched gears. I did internal medicine residency and then an advanced training and a fellowship at the Cleveland Clinic in Midlife Women's Health. So that was back in 2010. So before menopause sort of had its movement and that we're talking about now. So I feel really lucky to be in this field. And I feel so honored that, we're talking about this and that more celebrities and more media and more funding is going into understanding perimenopause and menopause to really just help women understand the access. Because as I always say in this time of this transition is if you are born with ovaries, you will enter menopause, right?
Yes.
The majority of women, that's between the ages of 45 and 55, 90% of women will go enter the menopause transition. And that's a big change in our hormones. And we'll talk about all the implications and how to understand that here in a couple of minutes.
Maybe we can just start with what is menopause. I mean, I think it's funny. We talk about it so much. I feel like it has become just daily conversation at dinner parties and cocktail parties, which, as you know, is kind of the premise of this whole podcast is, what are the people talking about cocktail parties that they're asking me as a breast radiologist that I might not know the answer to? So maybe we can start with what exactly is menopause, because, I have an idea of it as a doctor, but I'm not even sure I understand the full extent of what menopause actually is.
Yeah, let's start with definitions. I like that.
Okay.
So menopause really is defined medically as 12 months without a period. Now, there's a lot of women who, have IUDs or take contraceptives or have had hysterectomies or their ovaries removed. And so sometimes they're left wondering, like, am I in menopause? What's going on? So the medical definition is kind of strict, right? We kind of like our guidelines, in medicine. However, we know that menopause is not just one period of time. It's 12 months without a period, but the time leading up to menopause and after menopause also has some terminology that's really important. And that's where I think there's a lot of confusion and women wondering, where am I? So when we think about transition, perimenopause is, we have 2 stages, the early and the late stage. Early stage is where, you might notice some changes in your menstrual patterns, like bleeding is heavier, bleeding is lighter, periods are coming closer together. a lot of women start to experience symptoms. And again, this is sort of what's missing from our definition of symptoms of perimenopause and menopause. Things like sleep changes, things like frequent going to the bathroom more often, maybe some vaginal dryness, maybe some increased changes in anxiety or night sweats or things like that. And you have to be kind of in tune to your cycle to understand that, or some of even the symptoms to understand that. Late perimenopause is when women start to skip their menstrual cycle. So maybe missing 60, 90 days. And some women notice more symptoms during that time. So things like big hot flashes, night sweats, again, changes in libido. We'll talk about all the symptoms there, but
Yeah.
these are things that start to change. And again, you kind of have to be astute to recognize them. Then when we start to see, again, periods space out even more, the menopause transition at the years before and the years after. And then after the final menstrual period, those years are the postmenopause. So you're really living in the postmenopause for the rest of your life. So a lot of women say, I'm done with menopause, I'm finished. And it's like, nope, you're living in the
You're
postmenopause time.
okay.
And that, again, is where estrogen, progesterone, testosterone are at very low levels. The ovaries sort of shut down. They're not working anymore. There's no feedback to the brain to say, let's make some more hormones and ovulate and have a menstrual cycle. And so that presents sometimes a different set of challenges or just a different set of discussions.
Okay, wow, that's so much information. So thank you for that. It's really high yield what you just went through. And I want to kind of break it down a little bit more. So I think just starting back to the definition that you talked about. So it's really 12 contiguous months. So if you have 6 months of no period and then all of a sudden you have a little spotting, you're still in perimenopause, right? You haven't quite reached menopause yet. Is that a correct statement?
Correct. And sometimes,
Okay.
that's where tracking helps, but also your symptoms. And a lot of times women are busy, right? We're like managing and juggling a lot of things. So when I ask people, when was your last menstrual cycle? They're like, I don't know, sometime around Christmas, sometime around the last holiday, they don't really
Right.
remember. That can be helpful, or just again, connecting the dots with some symptoms. I mean, I always say, between 40 and 60, anything new joint pain, new hot flashes, new sleep changes, brain fog, things, these are all generally have some sort of hormonal connection, right? And so sometimes that just alone just validates what we're going through, even if you
Yeah.
don't have a menstrual cycle, or even if your menstrual cycle isn't changing very much. I didn't mention
Right.
one thing I want to is that the average age of perimenopause is 47, but the
Okay.
duration can last anywhere from, 4 to 7 years. So some women, even in their late 30s or early 40s, might start wondering, am I having these symptoms or changes in my menstrual pattern or all these other symptoms? And the answer is they could certainly be. We always want to think about other things in our clinician mind. We always want to think about autoimmune things or thyroid conditions or checking on
Right.
labs. But again, hormones, can play a large role in some of these changes and can happen as early as late 30s, early 40s for some women.
No, that makes sense. And I think, as we're talking about being from the physician standpoint, you always want to make sure it's nothing else. But, I think so many of these symptoms can be related to that. And I think it's really interesting. A couple of thoughts have come to my mind as you were talking. One thing I think is, we're having kids later and later. And I feel like I had my babies and then I felt like I had brain fog, but then I had young kids and now I'm going into my 40s. And some days I'm like, is that brain fog? Maybe it's now we're in the perimenopausal state. So it is interesting to think about these things as we move from having children and then you're kind of all in that. And then all of a sudden we're kind of moving into the perimenopausal state in our 40s. And I think it's just really nice to have kind of parameters on that. So it's in the back of our mind, which it might not have been before.
One thing to mention, you said in your 40s and post, children. I always say this, every day in my clinic. I say, every decade of life, presents women with some new joys and new challenges. So
Yeah.
what happened in your 20s with your periods or maybe taking a contraceptive, and then if you just choose to have, children, and then beyond, every
Right.
decade of life present you with some new challenges. So some women in their 40s start having more headaches or migraines with their periods, or they have heavy menstrual bleeding. And that's significant, especially when you're again trying to juggle a lot of things and you're bleeding through pants or can't wear white clothes or have to
Right.
limit what you're doing. So remember that, just because it wasn't before, now something new could happen in your 40s. And I think sometimes we think everything's going to go back to the way it was before we had children, but oftentimes that changes. And again, a lot of those changes are due to hormones.
Right. And that's exactly it, right? So whether we're experiencing things in pregnancy or post-pregnancy or perimenopause or menopause or postmenopause, it all kind of comes back to hormones. And that's why it's so important that we really get a handle on this. And the other thing I was thinking about as you went through that high yield of all the different stages of menopause is thinking about, again, on casual conversations that people are having, I'll hear people say, oh my gosh, my anxiety's been out of control. I haven't been sleeping. I must be in menopause. I think this is menopause. And really it's semantics, but really the term we should be saying is this may be perimenopause, right?
Correct. So I always like to say this, there's no one hallmark symptom of perimenopause and menopause. So,
Right.
we have estradiol, estrogen alpha and beta receptors all over our body, from our brains to our hearts, to our joints, to our muscles, to our genitourinary tract, vagina, vulva, bones, all of these areas. And so some women will notice things like, yes, sleep disturbance, or you mentioned brain fog, which is such an interesting term. It's sort of like,
Such an
our
interesting term.
or yeah. So, and now we're studying brain fog and really what that means, and the cognitive, like just sort of taxing cognitive load, and seeing how, women's brains in perimenopause and menopause are different than, perimenopause, or different than premenopausal brains in terms of like our white matter hyperdensities and how glucose is metabolized in the brain. So really our brains are sometimes working in overdrive. And that's really fascinating work by Dr. Lisa Mosconi. And then, other women are having things like joint pain, so low back pain, small joints that are hurting them, like their fingers and toes. Lots of silent symptoms of menopause. So things like
Mhm.
bone loss, which is really important, and why, I named my practice Bone and Body Women's Health, to really, again, focus
Yeah.
on osteoporosis, bone loss, muscle changes, just again, how we change, how that part of our body changes through the menopause transition. I mean, and some women will notice things like vaginal dryness, like I mentioned, frequent urination. And remember, some of this is left over from pelvic floor issues if you've undergone childbearing. Some women have
Mhm.
GI changes like constipation, diarrhea, slowing things down. So I know it sounds like all these bad actors, but actually,
Yeah.
these are changes that we need to understand. And as our world of metabolism and understanding, just like weight and aging and all of that, we know so much happens at the menopause, where when we decrease our estrogen, there's insulin resistance, which means, again, the glucose isn't getting chewed up and used in our cells as well. So that can contribute to, changes in our, visceral fat and where fat is distributed. And that's one of the, I would say, most common complaints that I hear, both sleep disturbance and weight and metabolic changes through the
Yeah.
menopause. So again, and of course, 70% of women complain of hot flashes or night sweats. And that's the one that I think is most outwardly sort of acceptable, a little bit more acceptable now, and one people sort of identify with. But some of the other ones that you mentioned, like sleep changes or mood changes or, metabolism changes, aren't necessarily always, linked to perimenopause. And again, we always want to be expanding our box and thinking about other things, but these are very common, and really, I think, again, something that we should normalize, and, understand that there are things we can do around this time, not just sort of like roll over and be like, okay, I'm going to accept them.
Right, right, exactly. And I think, again, it's just nice to have to be able to chalk off some of these vague symptoms to something because, for someone who may not have ever had brain fog or these musculoskeletal symptoms, et cetera, it might not seem a big deal. But if you're that woman going through that and you're saying, there is something that's off about my body, it's just really nice to have something to say, this could be menopausal symptoms or menopausal symptoms. It's nice just to be able to have a bucket to put that in. And then there are things that we can do about it, right? So I guess, what are some of the things? Maybe we start with someone like me, with someone a 41-year-old person who is looking towards going into that perimenopausal state in the next couple of years. Maybe I'm in the early stages now. What is something I can do to kind of prepare myself as going into that? And then when you're in there, what is something that we can do, or what are the things that we can do to help us get through it?
I love this. I think what happens a lot of times, for women, particularly again in their 20s, 30s, maybe 40s, childbearing or not, or just busy, working jobs, working in the
Right.
community, doing whatever you're doing. Sometimes we let some of those health screenings like slip us by, right? And I'm really big on that. All my patients know that, like, every time I see them, I'm big on health maintenance, and making
Yeah.
sure that, like, you're getting this is music to your ears, right? Getting
Yes.
your
Let's put
annual
in our mammogram pitch right now. I love this.
yeah, doing a breast cancer risk assessment. Man, we have moved so far forward. So really
Yeah.
talking, do we need to do genetic testing? What about advanced imaging, like with an MRI or an ultrasound? Do you need to see a high risk specialist? So really
Yeah.
understanding that. Thinking about colonoscopy. So the news flash is that women are recommended to get a colonoscopy at age 45, or some colorectal screening at least, starting at that early. Vaccines are important.
Yep.
Obviously, a tetanus shot if you haven't had one every 10 years. checking things like your blood pressure, your cholesterol. As I mentioned, we know with the perimenopause and menopause that LDL, or the lousy, I call it the cholesterol,
Mhm.
starts to increase a little bit as,
Yeah.
again, estrogen helps shuttle that LDL out of the blood supply. And so we need to be checking those things within the 5 years of menopause or even beforehand. Cervical cancer screening, as we all know, HPV and pap smears, if they've been normal, every 3 to 5 years. But again, sometimes that passes us by. So routine checks like that are really,
Yeah.
really important because, again, when we hit, the perimenopause or menopause, and we might have now a sort of a building list of things that are changing or bothering us, we want to make sure some of that foundational stuff has been done and checked. And I always think, if you haven't done that, it's not too late. We can do a lot of that blood work, your thyroid, your blood count, your cholesterol, your kidney, liver
Right.
electrolytes, all of that, mammograms, we can get that done within a couple of months and really say, okay, we're back on track.
I think that makes so much sense. Make sure you're really teed up to go into it. What about I know you're an osteoporosis expert. What about vitamin D at this time in my life? I mean, should we be taking vitamin D? How much should we be taking to kind of prevent bone breaks in the future?
Yeah, so both calcium and vitamin D are really important. A lot of women might feel like calcium or dairy is constipating or bloating or things like that. So
Hmm.
there's so many other alternatives now if you go to the milk and dairy aisle. So calcium is really important because it helps strengthen and mineralize our bones. And as we age and go through the menopause, as I mentioned, the 2 to 3 years before and after, we can lose a significant amount of our bone density. And if you haven't achieved peak bone density, meaning you have a lower bone density than maybe say your peers due to genetics, or if you missed your period.
And we know that bone density with our DEXA scans, right?
Right. And
Or
so there's
yeah.
a right, whereas a DEXA scan. So, just so circling back is that, yes, it's important because we want to strengthen or do the best that we can. We build our bone density through our teens and our 20s. It plateaus. And then at the perimenopause and menopause, we can lose some bone density. So
Hmm.
adequate calcium, really important. Checking your vitamin D level, which can be done in the blood test to make sure that the vitamin D is between 40 and 60 nanograms per deciliter. We are in Chicago. Oh my goodness, where is the sun this spring and summer? We have not seen
I'm
it.
ready
So
for it.
we can get some vitamin D through our skin, but a lot of us are slathering on sunscreen. And so those are both important. The DEXA scan is a little bit more controversial, interestingly, even though it's a low
Okay.
risk, low radiation, great screening tool. I would say it's equivalent to the mammogram, really. The recommendation is to get a DEXA scan at the time of the menopause transition if you have one risk factor for bone loss. So that can be family history, a personal fracture you might have had, low vitamin D, a condition that might lower the mineral density, like a rheumatologic condition, autoimmune condition, a cancer. These reasons, early menopause is a significant one. So if you've had menopause before 45, absolutely need a DEXA scan. And so most of the societies now are agreeing on that, but most
Okay.
women are not getting that message. So I think it's really important to try and do that around the time of the menopause transition as well.
Okay. And just one last question, just going back to the vitamin D and calcium. How much should we be shooting for a day? People ask me that all the time, and I just would love to
Yeah.
hear it from the expert.
So for vitamin D, vitamin D deficiency by most of the medical societies is defined as a vitamin D level of less than, between 20 or 30 nanograms per deciliter. So
Okay.
well, but a vitamin D level between 40 and 60, 80 would be on the upper end of normal. Sometimes that's okay for women who might have a lower calcium intake because vitamin D helps absorb the calcium a little bit
Right.
better. More isn't necessarily much, much better. We've looked at that at a study called the VITAL study at Harvard that looked at vitamin D levels, and it didn't show that it decreased risk of cancer or fractures. But again, we're not using it for that. We're using that to help absorb the calcium. It's good for mood for a lot of women. Vitamin D
Hmm.
receptors are in immune cells as well. So potentially, again, that helps with fighting infection. And again, that's one thing. I always say this is a toolkit, right? At the time of the menopause, vitamin D is one thing, but an easy thing to get, from supplementation, harder to get in food.
Yeah.
Calcium, this is one where, I always think, let's try and make it simple. There's so many things that we could, do every day, but calcium, generally around 1,000 milligrams of calcium is what women need. And even more if you're, nursing and breastfeeding or pregnant.
Okay.
So again, around 1,000 to 1,200. It's hard to get that in food. You have to read the food labels. You have to look at the back, but generally quick and dirty, most milk or milk sources, even oat milk, almond milk, soy milk, have about 300 milligrams of calcium if they're fortified,
Okay.
sometimes higher. Yogurt, cheese, non-dairy sources, there's leafy greens, these are all good sources of calcium. Nuts. So just trying to include some of these whole foods in your diet can be very helpful for getting calcium. And then PS, all the other good nutrients that you need to.
Okay, so we're talked about kind of teeing ourselves up for menopause. So when we're in menopause, what are the things that we should be doing?
Okay. So when we think again about menopause, we talked about the medical definition and some of the symptoms. And I always, I think the most common question that I get is, well, should I check my hormone levels? Right. And so the answer, of course, that no one likes to hear is it depends. Right. So,
Right.
when you're, in the perimenopause, estrogen and progesterone and testosterone can sort of fluctuate a lot. I always sort of say if you've ever been surfing, it's kind of like surfing a wave. It goes up, it goes down. Some days it can go up and down in the same day. So the reliability of the serum blood testing for those is tricky. Not to say we don't do them, but we have to be able to interpret them then correctly based on where you are in your cycle or where your symptoms are, or just kind of gives us a little bit of a snapshot. But sometimes we're trying to understand those together, with where the patient's symptoms and where they are in their cycle. In the postmenopause, there's no need to check your estrogen and progesterone if you're not on hormone therapy because we know it's low. It's like if you're pregnant, your levels are going to be super high. If you're in
Right.
postmenopause, your ovaries are shut down, they've retired. And so there's going to be no estrogen. And so in between there, sometimes we use that for some guidance. The Academic Medical Society, the Menopause Society, which I'm a really big advocate for and member of, and doesn't say to check blood tests. But again, I love recently my friend and colleague, Dr. Rachel Rubin said, there's the textbook, answer, there's the Instagram and social media answer, and
Right.
then like the
Yes.
clinical answer. And so we're in the middle, right? That's what we're doing, practicing clinical medicine. That's what makes it fun, exciting, and challenging every day.
Right.
Um,
That's a really
and
great point.
yeah, and then in menopause, what to do? Well, I think that we talked about all those symptoms. A large majority of women will be, candidates for menopausal hormone therapy. So what is that? So this is a big, large blanket term for replacement of these hormones that have declined, through the perimenopause and menopause. I find them
Mhm.
similar to like thyroid replacement. If you're on a thyroid medication like a Synthroid or levothyroxine, it's the same thing.
Okay.
We're replacing a fraction of the hormones that have been lost. Unfortunately, with the menopausal hormone therapy has like a bad rap, a scary rap, misinformation, and that all stems from 20 plus years ago from the Women's Health Initiative study that took older women further from the menopause transition later in their 60s and gave them hormones that are a little bit more antiquated than we use now, conjugated oral estrogen,
Right.
medroxyprogesterone acetate. And it showed some great things, but it also showed some things that were surprising based on the literature before that. What it showed is that women who were on estrogen alone, which they had a hysterectomy or didn't have a uterus, it decreased their risk of breast cancer, all cause mortality, heart attacks, strokes, osteoporosis, fractures, dementia, all of these things. However, the information that was shared during like the press conference was that breast cancer is increased, heart attacks, strokes are increased, and that was
Yeah.
only seen in the women who were using estrogen plus progesterone. And this is thousands and thousands of women studied, and the absolute risk was very low. So it was one additional breast cancer per 1,000 women per year in the study. So the risk of new onset breast cancer using menopausal hormone therapy over 7 years was very low, but that message scared the world, and hormone therapy was discontinued in masses. And now that's estimated less than 10% of women are offered or are on menopausal hormone therapy that might be eligible. So we've just had a
Well,
big rift and a big change in this, in this prescribing pattern, and then thus the treatment of menopausal women in the last 20 plus decades. And so I think that's pretty well documented now, and we're working our way back. So now we're really thinking this is more of a, we need to think about this as sort of a pendulum, right? So we need to think of, weighing the risk and the benefit when we think about talking about menopausal hormone therapy, which is FDA approved for hot flashes and night sweats. We call that vasomotor symptoms. Treatment of genitourinary syndrome of menopause, which is a mouthful for a constellation of symptoms like vaginal dryness, painful intercourse, frequent urination, urinary tract infections, and then third, prevention of osteoporosis. And so we
mhm.
have a large majority of women, as I mentioned, 70% of women have hot flashes and vasomotor symptoms for 5 to 7 years or longer. So there's a large majority of women who could be offered menopausal hormone therapy. I know I'm talking a
Okay.
lot, but I'm going to mention one more thing. There are some women who, either choose not to be on menopausal hormone therapy. They don't want to accept the risk of, of a blood clot, or they've had a history of a blood clot. They've had an estrogen dependent, breast cancer. They're having some abnormal uterine bleeding or elevated liver functions. And those are the women who, might not be acceptable for use of menopausal hormone therapy, or again, just personal preference, right? We all need to have
Right.
options. And then there are other non-hormonal options then to treat hot flashes. There's vaginal hormones to treat vaginal dryness. There's osteoporosis treatments. I mean, there's so many other, avenues that we can treat those other isolated symptoms in the menopause and postmenopause as well.
I think that's so helpful. I mean, I just think this is so high yield. I'll probably go back and listen to it multiple times because I think you really touched on so many things. I'd like to just take a few minutes at the end just to summarize everything. Let's see how well I do on this test and see how much I learned from you. So I think the most important thing to remember is the advocacy for menopause is there. It really is a movement, and we're so lucky that it's a movement. We're so lucky to be in this time as women, but also, everyone really, to understand some of these symptoms that we're going through. Over a third of a woman's life is spent in this time period. So it's so important for us to understand what's going on. There really are 3 stages. There's kind of the perimenopausal stage of this, which is kind of early and late, the menopausal, and then the postmenopausal stage. There are different things that we can do in each stage to help us kind of get through it and to treat it. In the perimenopausal, we're really thinking about teeing ourselves up for it. So really getting all our health maintenance examinations, making sure we're getting enough vitamin D and calcium to protect our bones for the osteoporosis protection. We're really want to make sure we're up to date on, as you said, music to my ears, our screening mammograms for sure. Also risk assessment for breast cancer, colonoscopies, etc. So make sure you're talking to your doctor about what might be good for you, making sure we're checking our thyroid levels and our cholesterol levels, and just really making sure that the foundation of our healthcare is really set to take us into that next phase, which would be the menopausal phase. And when we're in that phase, which these can last for many, many, many years, we're really trying to treat those symptoms. And so we're talking to our doctor about treating those symptoms. And in the past, you're right. I think hormone therapy did get a bad rap. And I love that you talked about it being a pendulum swinging back the other way. Hormone therapy might be right for you. So something to talk to your doctor about. Of course, as with all medications, there's always contraindications to things. So make sure you're talking to your doctor about if it's right for you in that menopausal and perimenopausal and postmenopausal phase. So I think we just have so much to learn. I think we could have talked for the rest of the day and I still would have so much to learn. I just appreciate your time so much. And thank you for shedding light on this very important topic.
You nailed it. You are ready for all the transitions and talking to your patients about all of that. That's incredible. And, so many great resources out there for education, the Menopause Society being one of them. Menopause.org is a great, there's videos, there's information, all of that is great.
And what is the handle that people can follow you at on Instagram?
So my practice is called Bone and Body Women's Health. I am located in the northern suburbs of Chicago in Winnetka, and it's my website is just my practice, boneandbodywh.com, and same with Instagram.
Thank you so much.